Hello, I'm Hunter Russ, Senior Program Officer at the Bob Woodruff Foundation. I welcome everyone joining the call today, and we look forward to hearing from our expert panelists. For those of you who may be less familiar, the Bob Woodruff Foundation's Got Your Six network is the largest non-governmental network of organizations serving our military and veteran community. The network includes over 350 veteran serving organizations of varying sizes, maturities, and focus areas. I'm confident this content will be helpful for our partners who are boots on the ground serving the military and veteran communities. Veteran suicide remains one of the most urgent public health challenges facing our nation. Suicide is the second leading cause of death for veterans under the age of 45, according to the VA Suicide Prevention Report. We believe that suicide prevention is not just the responsibility of mental health professionals. Everyone, whether they work in veteran services, education, libraries, food banks, or local nonprofits, have a role to play. That's why the Bob Woodruff Foundation is expanding its awareness and training opportunities to ensure all community members can recognize warning signs, engage in thoughtful conversations, and help save lives. I'm excited to introduce our first speaker to share more about the Columbia Suicide Severity Rating Scale as a vital tool for assessing suicide risk. The U.S. Department of Defense said her work is nothing short of a miracle, and that her effective model for improving the world will help us propel closer to a world without suicide. Dr. Kelly Posner, founder and director of the Columbia Lighthouse Project. Dr. Posner, thank you so much for joining us today.
So excited to be here, and I'm going to dive right in. And again, I'm going to have way too much information than I have time to share, but I hope I'm going to really cover a lot of helpful, inspiring themes. So we're going to go through the Columbia Protocol questions. And one of the things that it's important to understand is that one of the most helpful benefits of the Columbia is that it shows us who needs help and what level of care they need, whether it's, an outpatient referral or they need more imminent risk. So the first question is, have you wished you were dead or wished you could go to sleep and not wake up? And, that's an important question, and it's a potent question, but it's the lowest risk question. What we know from the science is that when you say yes to that, you're 5 to 6 times more likely to end your life, but over a 20-year period. And one of the things this also does, this question, is really gets more precisely at what is suicidal ideation. So people have thought about what is passive ideation, I'm better off dead, thoughts of my own funeral. Those things are important, but they're not actually suicidal. They're actually more congruent with mood and depression. So the more precise identification of every level of risk is one of the benefits of the Columbia. So the second question is, after you ask, have you wished you were dead or wished you could wake up and wish you could go to sleep and not wake up, is have you actually had thoughts of killing yourself? And only if that question is yes, do the next suicidal ideation questions get asked. Have you been thinking about how you might do this? I thought I could take pills, I could jump off the bridge, but I'd never do anything about it. And the next question is, have you had these thoughts and had some intention of acting on them? Now that has been a game changer question on the Columbia. As you go through each question on the Columbia, risk goes up every level. Every question, risk goes up to a degree. Okay, but when you get to this question, look at how much risk goes up. 1,400%, 600%. And with veterans, the first time ever, the Columbia predicted short-term subsequent suicidal behavior. And this particular question, veterans with any intent to act were 6 times more likely to have a suicidal behavior. And it doesn't mean that somebody who has thoughts with methods, I could jump off the bridge, I could take those pills, isn't at risk, but risk goes up so dramatically when you get to this question. So with these high risk questions, we know we need to go to a further evaluation. And again, the difference between 3 and 4 is 3 is, I thought about how I might do it, but I'd never do anything about it. When they get to a 4, they say, I can't tell you. There's some indication, even if it's 1%, that they're worried they might act on those thoughts. And then have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So that's intent to act plus a plan. And you're already in this very high risk category. And then that gives you, when they make a specific plan with intent, you're at another level of risk. And then the other final, this was another game changer question on the Columbia. Have you done anything, started to do anything, or prepared to do anything to end your life? And you can give them the examples, like taking pills, getting a gun, cutting yourself, uh, going to the roof and not jumping, et cetera. And the importance of this, it probably is very intuitive and obvious, but in the past, a veteran would have been lucky if they got asked about a suicide attempt before the Columbia. And then you miss all those very important preparatory behaviors, interrupted attempt, aborted attempt. An interrupted attempt is when somebody stops them from doing something. So, the orderly pulls the veteran off the roof, the mom pulls the pills out of her hand. An aborted attempt or a self-interrupted attempt is when they change their own mind. So they have the pills, they put them down. And a preparatory behavior, which is the other category, is, anything beyond a verbalization. Okay. A thought or a verbalization is not a behavior, but anything beyond a behavior. So writing a note, writing a will, but even I'm scrolling the internet, looking in the dark web for ways to kill myself. That is a behavior when you're typing on that computer. A friend who texts her friend, a goodbye message, that is a behavior. And of course, again, it seems, clear why we can't afford to miss all of those other things that we weren't asking about before that are so important to identifying veteran risk. But look at this science. Unbelievable. An interrupted attempt, again, somebody pulls them back from the roof, pulls the gun out of their hand, was 4 times as predictive as an actual attempt. Each one of these other behaviors are equally or more predictive. And guess what? They represent the overwhelming majority of what serious suicidal behaviors veterans or their family members will engage in. Only 1% of people typically get a high risk answer on the Columbia, but of those, 87% of behaviors are these other behaviors that we weren't asking about before. So what that means is in the nation, if we were not doing the Columbia, we could miss 9 million serious suicidal behaviors. So I just want to spend a minute on triage. So, I was starting to say that one of the reasons the Columbia is the global method is because it's the first time we have science-based thresholds for who's at imminent risk. We did not know who to worry about before. So that policeman had to take everybody to the hospital. That school had to send everybody to the hospital because, again, they didn't know who to worry about. And you know what the problem is with that? One of the problems is that actually can do harm. Do you know what happens when you intervene with somebody that doesn't need it? It actually shuts them down from further treatment when they do need it, right? So it actually not getting that high risk care delivery to only those people who need it can actually do harm. And we also know from the science that people who receive the lowest level of care in the community have better outcomes. They ask for help more often and they have better quality of life. So this is very formulaic. When you're using this for a triage, it is formulaic. So low risk is answers to questions 1 and 2. Moderate risk is 3, or a behavior older than 3 months, and high risk is a 4 or 5 in the past month, or a behavior in the last 3 months. And all high risk means when you're doing it the first time is that you need a further evaluation. Again, a triage tool. We're now going to go into a few role plays, demonstrations, okay? Hi, Wendy.
Hey, how you doing, Kelly?
I'm good. I'm glad that we're here today. I understand a lot's been going on.
Yeah. I'm just worried about my husband. John's been I've talked to you about this before, but I think he's getting a little bit worse. I don't know. He's not sleeping and I the other day it was just weird. I came home from work and it was dark, a little bit dark. It was getting dusk and the house was completely pitch dark. And I walk in and there he is, just sitting in a chair and not doing anything, just kind of like staring out in space. And I could see that his lunch was still sitting on the dining room table. So I don't even know how long he's been sitting there. And it worried me.
So- Sounds like he's pretty depressed, actually.
Yeah.
Let me
Yeah.
ask you a few questions related to that. So has he said anything about wishing he were dead or could go to sleep and never wake up?
Well, I know he's had some thoughts about suicide but we've talked about that.
So what were those thoughts that he told you that he shared?
Well, he said that he had thoughts about just going away, just not being here anymore. We didn't talk about specific, well, he did tell me some things too about that he did have a plan at one point,
What did
but
he what did he share?
he said that he would be better off not being around us, that we'd be better off without him, I think is kind of more of what he said. Um, and then I did talk to him and I said, so I did ask him, are you thinking about doing something to yourself? And he said, yeah, I've been thinking about, just, I've been thinking about suicide. That's what he told me.
Did he give you any more details, like how he would do it or what his plan
He
was
said he
exactly?
thought about it and he did have, he thought about, because we have guns at home and he had thought about that, although they are locked up. But he thought about that and then, but he assured me that would never happen. He said, I would never do it. I would never leave you.
Okay.
Yeah.
And did he and when was that?
Oh, I want to say about 2.5 months ago. Well, actually, maybe it was about, no, maybe it was about 6 months ago.
Okay. And any other things, like has he ever done anything, started to do anything or prepared to do anything to end his life, like writing a will, writing a note, collecting pills, getting, like you said, he thought about the gun, but, did he actually do any behaviors or try to hurt himself or?
Not that I've seen. He just said that one day that he did pull out his gun and he set it aside. That's all I know.
Okay, well, sounds like he's really, really suffering and we should work together to try to get him some help. So thanks for that.
Sure. Yeah, thank you.
Yeah, so that was a spouse and of a veteran that we just demonstrated, and that's really important because, probably 75 to 80% of people who take their lives, veteran or other, kid, do it in their homes, right? We know that spouses are very often the first line of defense. And so critical, if for every veteran that's at risk, if the spouse can have the Columbia and ask the questions, that's what we aim for. And this seems like he came up as moderate risk. And just to start with the first question, has he wished he were dead? Has he? He said, he's talked about being better off dead. Really important, but indicates depression. That's different than wanting to be dead. So if I were there with the veteran, I would have said, but do you want to be dead? So we don't actually have indication yet of that first question, but we do have indication that he's had, active suicidal thoughts. He said he thought about a gun. So he had thoughts with methods, which is number 3, which is moderate risk. But he said, I would never do it. I would never leave you alone. So he did not have a 4 or 5. And he had a behavior, we were told that he pulled out the gun, okay, and then put it down. So that's clearly a behavior, and that's what we call a preparatory behavior. It's like grabbing the pills from the cabinet. He pulled the gun out of the gun safe, right? But it was more than 3 months ago. So we're still in moderate risk, but a very, very helpful, interview. So, and brief and potent, right? So we knew what this veteran needed. He needed care. And, with low and moderate risk answers, we still want to facilitate treatment and referrals, right? So what with low and moderate risk, a mental health referral is going to be helpful, is going to be helpful, and do what you can to connect them to those referrals in whatever system you have. Okay, so we're gonna jump right into another one.
Gonna change.
But Wendy, it's good to see you. Thank you for talking to me. I understand that there's a lot going on right now.
Yeah, I told you we just paid off the kids, college loans, and now I just lost my job. So, and I'm having issues with John and I, and we're starting to fight a lot, and yeah, just a lot going on.
I'm so sorry. So it seems like there's just a lot of stress. So,
Yes.
so let me ask you some questions, okay?
Mhm.
Have you wished you were dead or wished you could go to sleep and not wake up?
No, not really.
Okay. Have you actually had thoughts of killing yourself?
Yeah, I've had definitely just to get away from all this crap.
So can you tell me a little bit more about that? Have you been thinking about how you might do that?
Yeah, I mean, we have guns in the house, but I don't know. That's not something I have been setting aside some other stuff.
Like what?
I've got some just medication that I take.
What is that medicine?
It's a antidepressant med that I take.
And have you thought about how much you would need that when you set aside the pills?
I'm just trying to gather as much as I can. I know that I just got changed to different pills, and I'm still getting those other ones though, so I'm just holding on to those.
Yep.
Just in case. Just in case, because I'm to the point where I just can't take it.
Yeah, you want the pain to stop, huh?
Yeah. Mm-hmm.
When you have those thoughts, with the gun or the pills or whatever, do you have any intention of acting on them?
I've definitely thought about it.
You
Mhm.
you worry that you might act on.
Yes.
Okay.
Yes.
And have you started to work out a specific plan or the details of how to kill yourself? Like, when John goes out for work, I'm gonna,
Yeah, I think, any time of day I'm home alone now, without a job. So of course I could do it anytime during the day.
yes. So you could, but have you really worked out the very specific details when, where, how? We know the how, but
Not exactly the when, but I know that I would do it at home and I would use these pills that I've been setting aside.
okay, all right. So thank you. And also, have you ever done anything, started to do anything, or prepared to do anything to end your life? We talked about the pills, we talked about the gun, other things like, writing a note, writing a will, looking for other methods, getting any other things like that?
Yeah, a couple of weeks ago, I actually took a handful of these and I fell asleep. I was kind of afraid. I fell asleep. And John came home and I was still asleep and he just let me sleep to the next morning and I woke up. But yeah, but
And
I
when
didn't take more than I think I took 3 or 4.
and when you took those pills, part of you was doing that because that was the way that you were going to end your life.
Yeah, I was going to do it at that point. Yeah.
Yeah. And then anything else in your past, like I said, writing a note or giving things away or?
I started to write a note, but I stopped. I started to at least tell everybody goodbye
In this instance or another time?
another time.
Okay. And anything else?
Mm.
Okay. All right. Well, thank you for sharing all that. I know it's difficult, but let's and I don't know that it's difficult. It really feels good sometimes to
Yes.
share. And
Yeah.
the most important thing is that let's get you some help. And there is help, and we can, you can start to feel better. So let's start that process right now. We can make a call together. We can call 988.
I don't
What
want to call 988. I don't want to seem like a weak female veteran, right? That people hear about. So I do have somebody at the VA that I have seen before and I really liked her. So yeah. And I do have her number.
Great. Well, then let's call her together now, okay? So that's wonderful. And that you have a connection with somebody. And I just wanted to also say one more thing. This is this myth that, that this makes you weak, but actually it's the opposite. Getting help, seeking help makes you strong,
Mhm.
and you are strong. So
Thanks.
let's make that phone call together now.
Thanks, Cal.
Once again, thank you so much for sharing about this. We know it's a great tool and a great resource, and I'm really excited to be able to continue to have this conversation and bring it to our attendees today. So thank you so much, Dr. Posner.
No problem.
I'd love to transition to our panel, which is going to feature about your 6 partners who use this tool in their daily work. Thus, it is my great pleasure, to go ahead and introduce our panelists. We have Dr. Katy Dondanville she is the Associate Professor and Research Director with the Strong Star Training Initiative, and Face the Fight. We also have Gabrielle Piomelli. She is the Program Manager with Vets for Warriors. And lastly, we have Samantha Wade, Director of the Columbia Region, Operation Stand Down Tennessee. Thank you all so much for joining me today. Really excited. I know we just heard a great talk about from Dr. Posner about the Columbia scale, and really excited to hear how each of you work that in different opportunities or different techniques into your programming. So Gabrielle, I'd love to start with you. Your team uses this as part of the intake for everyone who calls in. Why did you guys decide to do this?
So asking with every call for us not only ensures the safety of all the clients that are calling in and getting to the appropriate support level, appropriate resource, but it also kind of like Kelly was highlighting earlier, normalizes the conversation. So there tends to be a lot of anxiety and a lot of stigma, especially in the military community, surrounding mental health and surrounding suicide. So using the scale with every call, it helps the peers feel more comfortable asking the questions, and it helps the clients feel more comfortable answering them. So while we focus on one call at a time for us, again, as highlighted before, it's not only impacting the caller, but it's impacting their family as well. So asking these questions that, should be routine and can make a big difference.
Samantha, I'd like to shift to you next. What does this look like at Operation Stand Down Tennessee? So a little bit different of a model versus the Vets for Warrior models. But can you walk us through what a typical case of the Columbia screener is during your intake and intervention processes?
Yeah, of course. So at Operation Stand Down, we actually use a tiered assessment approach. So when a veteran comes into one of our service centers, we kind of start the intake process there. Each veteran completes a psychosocial screening along with the Warwick-Edinburgh Wellbeing Scale. Based on the results of those initial assessments, that's when we would then administer the Columbia to further evaluate the severity.
Samantha and Gabrielle, what do you guys do when you get to that next stage of a yes or a concern in those responses?
So for us, if a veteran indicates yes on the Columbia, we would actually then enroll them in the Staff Sergeant Fox Suicide Prevention Program. We have that grant program through the VA. Our case managers then conduct further assessments to evaluate the severity and determine an appropriate action plan. That includes ongoing follow-ups, regular check-ins, support services, just to kind of ensure that continued care. We also coordinate closely with local VA clinics, VA hospitals, vet centers, and if necessary, the team will escalate the situation to emergency services to address immediate safety concerns.
As you know, Vets for Words is primarily a peer support line. So because we're not clinical, whenever we get a yes on that scale, we do have clinical staff on each shift. So the peer notifies one of our clinical staff to monitor the call, provide coaching, assistance. If they wind up being an at-risk client and they need a higher level of care, oftentimes our clinical staff will take over that call. Similarly, like Samantha said, contact emergency services or link them with the Veterans Crisis Line, but making sure that they're at the appropriate level and not just receiving peer support. After that, we do follow up with them though, to see if they want ongoing support in another, sense instead of just clinical and mental health support.
Katy, Dr. Dondanville, could you summarize the key aspects of the screener that the audience should know?
So I have the little card that Kelly has lots of swag. One of the things about this screener and all the resources from the Columbia Lighthouse Project is it's really developed in a way that anyone can use. So I think like one thing for everybody to consider is that it's so important. As a psychologist, not everybody's going to make it to my office. And sometimes I'm navigating the world, not in my professional role. And so the way that the screener is set up is there are 2 questions that you ask all people. And if someone says no to those 2 questions, then you ask a final question related to, so the first question is, have you wished you were dead or wish you could go to sleep and not wake up? And the second one is, have you actually had any thoughts about killing yourself? If they were to say no, then you just ask about if they've had any preparations. Have they done anything, started to do anything to prepare to end their life? But for many people, the answers are no. And just like when I go to the dentist, they take my blood pressure. This is one thing that, if it is more, as Kelly was saying, systematically embedded in places where people live, work, and play, then we have more opportunity to identify and do some of the great work that Gabriella and Samantha were talking about, which is helping connect people in need.
So Dr. Dondanville, I'm going to stay with you. So as a clinician, as a psychologist, do you have concerns about non-clinical people screening for suicide risk?
No. And I think we as community members and citizens in our community, I wish that this was embedded in more places. And we really need, as community members, to have suicide prevention and screening like this in all nooks and crannies, whether it's schools or gyms or places where we frequent. That is the way that we can really make change in our communities.
Yeah, and even going, kind of pulling on that thread, even going beyond, maybe a veteran space, but going into those personal spaces, like you're saying. So veterans are a part of the community. They aren't just kind of in their own separate little bubble. So being sure to have something like this as a resource in all aspects is really, really important. Gabrielle and Samantha, I'd love to pivot back to you guys. So when you guys started implementing and using the Columbia screener, was there any concern or, caution from your teams about that process at first? Gabrielle, we'll start with you.
For us, there was, I'm going to be honest. And initially, as a clinician, I was also a little concerned, having peers, especially them reaching out to me, being concerned, asking clinical questions, falling prey to those myths of, if I ask the question, am I putting the thought in their head? Am I making it more likely? But I think once all of our staff understood the reason, like the why, everything kind of fell into place. And the more training we got them, we offer a quarterly training for them just to make sure everyone is fresh and prepared. That made them feel more comfortable, not only asking the questions, but providing support, instead of tiptoeing over sensitive issues and being afraid, like, whoa, that's not in my lane. This kind of opened that discussion up for them and made sure that they were prepared for any type of call. And also knowing, who to reach out to in the event of a crisis. That opens so many doors for us to have more of a comprehensive, more supportive type of environment for our staff and our callers.
Yeah, Samantha, I'd love to hear from you as well.
Yeah, so a little different. There was not any major concern from our team, but We
Mhm.
really prioritized and made it a goal to train all of the case managers prior to implementing this so that case managers were confident and felt equipped asking direct questions about suicide.
Absolutely. So it sounds like there was some role play or, some opportunities to kind of maybe have that conversation or have those questions in a safer space. I know I've done some
Yeah.
mental health first aid training and had to ask the question, and I was like, this is the scariest thing I've ever done. Like, but being able to have some training and support with that definitely makes a difference. So, Gabrielle, we'll start with you. How often do you see clients screening or indicating risk when you guys are using the scale? And what is it? We talked a little bit about connecting them a little bit higher, but what truly happens if somebody indicates that higher risk?
Absolutely. So, like I said, the majority of our calls are not, crisis calls, but asking those 3 questions to all the callers, we do get the occasional yes. And now it's just part of our routine. It's part of our SOP. Someone says yes, a clinician gets involved, they listen, they monitor, they coach. Sometimes it's just coaching with the peer and the conversation goes fine and
Mhm.
on goes the peer support conversation. Sometimes they need an additional resource. Sometimes they need to speak with the Veterans Crisis Line and arrange a follow-up because they do have, the suicide prevention coordinators available to
Yeah.
them. And sometimes it's just a conversation with one of our clinical staff. They might not be an imminent threat, but they might need a little bit of clinical support. So we do that and then we set them up with peer support for the future. We make sure we're checking in. And again, every time they call, we ask that screening one more time to just make, hey, is this what's going on? Anything changes? So no matter how long they're open with us, a day, a week, a month, years, we're always making sure that they have the support that they need.
You mentioned asking that question again when people call back or as you guys continue to work with them. Was there pushback from clients as you guys introduced the Columbia scale and being incorporating that as part of your process?
Not as much as we anticipated. So,
Mm.
you're always going to have, some clients call in, some callers call in, and they're going to be resistant to answering any information, whether it's their name, their phone number, where they're
Yeah.
located. But the majority of our clients kind of just took it in stride. They know that they're calling in for support. We have people who call in every day for support. So they know it's
Mhm.
part of what we do now. They know it's part of the routine. We're just checking on them. We want to make sure they're good. And then they get the peer support that they were looking for.
That's exciting to hear that there wasn't as much pushback. I know sometimes there can be that resistance. And Samantha, you mentioned if they do screen a little bit higher or indicate, you guys enroll them in the Staff Sergeant Fox grant program for you guys. And what does that kind of look like for next steps in that capacity for you all?
Yeah, so if they enroll in the suicide prevention program, we would then create an action plan, and it can include steps for several things. It can address mental health or maybe employment.
Mhm.
And we also create a safety plan with that as well. And we would work with them to get connected to, because we're non-clinical as well. So we would get them connected, to the VA, either a, community-based outpatient clinic, the hospital, whatever's appropriate, or I know Dr. Posner mentioned Centerstone earlier. So that's another kind of referral that we'll send out as well.
And so when you guys are making those connections and those referrals to community agencies who are able to support it at a level that you guys may not be able to because you're non-clinical, what does that conversation look like? Are you on the phone with them or is it a referral, kind of a longer process? What does that look like?
So it kind of just depends. We want to empower our veterans to make the appointment by themselves, but we also understand that some need a little bit more support. So sometimes our case
Mhm.
managers being in one of our rooms, with them privately making that appointment. We're lucky enough here in Columbia to be across the street from an outpatient clinic.
Mhm.
So we've also just physically taken our veterans there to help them make that appointment.
Wonderful. And Gabrielle, I'd love to hear from your perspective as well. So thinking about being at a more national coordination center or call center, what does that look like for you guys?
So yes, I mean, it would be great if we could also do that. I'd love to walk someone to a service, but obviously we're over the phone. So we do what's called a warm handoff, a warm transfer. So
Mhm.
whenever someone does need that extra level of care, or that extra support, whether it's transferring to one of our clinical staff or Veterans
Yeah.
Crisis Line or even another resource, we make sure that we get the client or the caller on the phone with that organization to the best of our ability, explain what's going on, explain what they need, because just like Samantha indicated, we're not always the best at advocating for ourselves. So we want to make sure we're advocating for our community.
Yeah.
So we do that warm handoff, we explain what's going on, we explain what's needed, and then once they're set, we disengage from the call. And again, if there's someone we're working with that's got ongoing support, we make a note in their chart so that we can later follow up. Was that resource helpful for you? Can we find you a different one? You know, what really is there an additional need for?
Absolutely. Dr. Dondanville, we'll pivot to you. So we've heard a little bit from each of the other panelists about how they use it. So how do we know the screener works? So obviously they're able to make a connection, but how are we knowing what it really means and what the outcomes are of the screener?
Yeah, so Dr. Posner and his team has done so much research on the screener. And when we think about what it means to work, I think we want to think about a couple things. One is that many people are existing in this world with these thoughts, and they are not talking about it proactively with anyone.
Yeah.
And so one way that asking these questions works is to really allow a space for someone to disclose that.
Yeah.
And one of the things that we really want to cultivate is helping to identify people who are distressed and in need before it's at a crisis where we're calling 911 and the outcome is to hospitalize someone. We want to be able to talk with people about other options. Those options may not be so urgent or emergent. And the conversations that Gabriella's team and Samantha's team have with individuals may be those conversations that are critical for people to even consider mental health treatment. And so what I would say is that those are examples of how that Columbia screener works in facilitating. And I want to invite Kelly to kind of jump in again. Yeah.
Yeah, I wanted to say, when you think about it working, right? So many examples of it being connected to reductions in suicide, right? So state after state, since doing the Columbia, we've lowered suicide. And why? It's because it's connecting the right people to the care they need. And that's really important. And I think to Katy's point too, what we know when we avoid getting someone to the hospital. And the thing is, when you intervene with somebody when they really don't need it, or the intervention is worse than it needs to be, it actually does harm. It shuts them down from treatment when they do need it. And we know that when you intervene in the community, people have better outcomes. They ask for help more often and they have better quality of life.
Dr. Dondanville, I know at Face the Fight, there's some other trainings. There's no one way to ask a question. There's no one training that is perfect beyond any. And so I just wondered if you wanted to touch on anything that Face the Fight is doing as well, just to kind of think about it from a holistic perspective.
Yeah, so two things I'd like to highlight within Face the Fight. So we have screening, which is identification. Then there are interventions like crisis response planning or safety planning, which are really about proactive strategies to manage distress, and creating a plan when we're not in crisis allows us to look to use that plan, right, when we are in crisis, and to think about what are the things that I know work for me to help get through those dark times. So crisis response planning is a training that we offer monthly. This is an intervention that can be done by peers. The Vets for Warriors team is utilizing this along with clinicians. It is also an intervention that can be used universally. So who in this world doesn't experience distress at times? And when we're really distressed, like our thinking is not so great. Sometimes people use this like little flip, our frontal lobes. but it helps anchor, like, what are the things
Mhm.
I need to do when my thinking isn't so great? So that's number one. And then the second training is related to one thing that Kelly mentioned. We know when veterans and service members die by suicide, they often are using a firearm. And so one of the things that is really important is securely storing firearms, and especially at times of distress, considering additional measures to have time and space. And so lethal means safety is an intervention that is something that clinicians can use, but any of our research that we do about lethal means safety, the last person that a veteran wants to talk about firearm safety is someone like me. And so
Yeah.
our community members, first responders, peers, friends, loved ones, hey, I'm worried about you. So that training is really about helping to have that conversation and think through opportunities to consider adding more time and space.
Can I just add to that, I was saying, unlike the myth, people think, oh, you have your head set on suicide, nothing you can do about it. It's actually the opposite. When you intervene up until that last moment, 93% of people will never go on to try again. So I said, people put it, the way that lethal means safety synergistically works with the Columbia has been really important, like the gun safety storage box where you put it on, when somebody's on the bridge, the policeman asking. Everywhere there's access to means is where we need to embed these questions so we can save those lives up until the last moment.
Gabrielle, I saw you nodding along as Katy was talking, and just wanted to make sure you didn't have anything to add as well.
Oh, no, I mean, I was just agreeing. So actually at Vets for Warriors, part of our peer support model includes not only doing the Columbia with every call, but also we have a lethal means discussion with every call. We're documenting, which types of interventions they're willing to try, willing to consider, meeting them where they're at in their stage of change. And we also have all of our staff complete lethal means training, the CRP training, and the Columbia training. So we've incorporated all three of those things. And again, the data shows that it's making a difference. So, that's really where it counts.
And I think the Vets for Warriors data is like, after they started to do this, identification went up 317%, 68 crisis referral plans. Like they just saw the fruits of this so beautifully.
Samantha, I just wanted to follow up with you. So you mentioned that there was kind of a multi-step assessment that you guys do for people who come. So, if people, what happens, for those individuals who don't need to get to potentially have the suicide or the Columbia scale as part of their intake?
So the way that we have the psychosocial and the Warwick well-being, more often than not, we're seeing that those scores indicate that we need to ask the Columbia. So from there, we'll always ask, those two questions that everyone's talking about, regardless of what we think is going to be like perceived risk based on the, scores that they had on the other one. It just kind of helps guide. But like I said, we're asking the majority of people that come in for that first time into one of our service centers.
That tiered approach is not optimal for identifying veterans at risk. Triggering into the Columbia is not state of the art because people suffer in silence. So, optimization is everybody gets it, like you get that blood pressure or vital sign. And I think it's really important for people to hear that.
So Dr. Dondanville, so these are just initial engagements. So for someone who's new to these programs, how do you know they're going to answer the questions honestly? So just thinking about your perspective from there.
That's a good question. I don't know that it matters if the first time I'm being asked the questions, I choose to say no, because I'm not sure about you all yet.
Yeah.
Right. And then because, Gabriella is following up and asks me every time, that may give a window for me to say yes. So I don't know that we need to be so worried that people are not going to be honest, but right away, but really think about how we as programs and as community members and as colleagues and individuals like continue to show up for people so that we can create that.
The good news is that 99.9% of people, when they're suffering, they want to be asked. So the disclosure, this myth that, you know, you're going to cause somebody or they're not going to want to, they will answer and they will be forthcoming and they're actually grateful for it. You know, the data shows that it reduces distress when you ask.
I do also just want to comment because yeah, I agree, though I don't think it matters necessarily if they're always 100% honest that first time. Because an example one of our supervisors gives when he trains new staff, and that I give when we train our staff, is someone who called in, had a relatively pleasant, normal, unalarming, unassuming conversation, called back a week later and said, I had a gun in my lap that entire time, and you saved my life just by talking with me. So giving them that space that we keep talking about where they can be themselves and can be honest. And even if it takes them a week to come to terms with, we're here for you, we're comfortable, we can handle it, it can still save lives because that's the message. They're getting connected. They have someone who follows up with them the next week. And, you know, it gives them a reason to kind of think twice about what their plans might be.
From what everybody said, I think that's really kind of the key for suicide prevention. Is it doesn't always matter if you get the question exactly right. It doesn't always matter if it's perfect in the way that you frame it, but just being able to be there and be a support system, even if it's not perfect, but still being able to show up in some capacity is, you know, sometimes at the end of the day, the most important part of this role that we have, and being able to support veterans and their family members and being able to expand that question. So I know we're getting close to time, as I mentioned. Gabrielle, I'd love to ask you just one more question. You mentioned earlier that you guys do regular trainings to kind of help make sure that these questions don't get stale or anything like that. And so can you share a little bit more about, you know, kind of that process of how you guys got to that stage?
Absolutely. So initially when we brought this on, it changed our approach as to how we were doing it. And because we're a 24/7, 365 program, you know, we have per diem staff, we have part-time staff, we have full-time staff. It's important to make sure everyone is on board and tracking with all the changes and all of our routine things as well. So every quarter we provide what we call a sustainment training. So we review all of those things, the Columbia, the CRP training, the lethal means trainings. We give opportunities for them to attend with our staff and outside as well. So we make sure all new and current staff are attending these just to make sure, again, if they have questions, because they're the ones on these calls all the time and not always is there a clinical ear. So if something came up and they were unsure about it, they can reach out, they can bring it up in training so that other peers can learn from their experiences, you know, because there's always going to be something we didn't know. There's always a chance to learn, to grow. So even though the trainings are almost the same every time, I always get a new question. We always learn something new. We always get to have a new type of conversation surrounding it. So that's the reason we're doing that.
And I think that's a really interesting perspective that you mentioned, of being able to have a continuously new conversation about what potentially is, I don't want to say it's a run-of-the-mill conversation, but it's, you know, you guys are doing these trainings regularly. So being able to have them stay fresh and stay something that remains relevant and that you guys are adapting to as needed or changing is really great to hear, and being able to implement. But I know we are at time, and really appreciate everybody joining us today. We had a really great conversation. And so as we wrap, I just want to stress that these conversations don't end with today's discussion, but are really just meant to serve as a start. And so we are really grateful to work alongside partners like you all who have joined us today as panelists and also as attendees, to be able to learn more about this topic and share the work that you guys do and some of the suicide prevention tools that are out there and how they can be implemented in their communities as well. So I want to say one final thank you to our speakers and our panelists today, and then also everybody who attended the webinar. We will share resources that were mentioned, and we will also follow up with emails and any questions that came in through the Q&A when we send out the recording as well. And if you have any questions, please don't hesitate to reach out. We thank you guys so much for joining joining us today, and I hope you all have a wonderful rest of the week. Thank you. Bye-bye.